Thanks, you guys, for having me here. This is really an honor. Obviously, Torrance National is one of the flagship hospitals, children's hospitals in the United States. So to be here is actually an honor for me. So I'm going to talk about a journey, and a lot of you have talked to me about the beginnings of your journey in your career in pediatric emergency medicine. And pediatric readiness has been a journey for me for my whole career. And so I'm going to take you to the past, the present, and maybe a little bit of the future. First of all, no disclosures. Not that exciting of a person. And business training. Now I've got, started an IPO. Anyway, so let's talk about the past. First of all, it just being involved in emergency medical services for children, really the past had been focused on cardiac and trauma care. The beginnings of EMS and emergency medicine in the United States focused on those particular issues, trauma and cardiac care. And once those systems were in place, it became clear the next question is now what about the kids, right? And this happens in a lot of areas relative to the care of children. So some of the specific needs that were identified as needs for uniform pediatric equipment guidelines, and that has since been solved. But at the time in the 60s, throw yourself back to that time period with very early EMS systems. The first ones really were in Dade County and Los Angeles, 1969. So now we're really talking 70s and early 80s. There was no equipment. There was no national education. There were no actual objectives to care for a pediatric patient in the out-of-hospital setting, nor were there any guidelines for emergency departments at this particular time. There was a need for some kind of plan to get children from community hospitals to tertiary care hospitals like this hospital, but those plans didn't exist. And then, again, there needed to be guidelines for emergency departments as well as the out-of-hospital setting. Jim Seidel, who is my mentor at Harbor-UCLA, developed a program and thought of it in the early 80s, and it's called an EDAP, so Emergency Departments Approved for Pediatrics, meaning that if they met specific guidelines, we come up with some guidelines that, some standards, so to speak, then pediatric patients could be delivered directly to those emergency departments that had the equipment. And what I had found, I was kind of relating this to some of you, I found in my fellowship is that children would show up and there'd be no equipment to take care of them at all. Even in the emergency departments, we would scramble to find all the equipment and where they were at. At Children's Hospital, it's very different, right? I worked in an academic center, but we saw adults and children, and and in many places it's integrated. Ours, we were even, one step ahead of others because we separated out children. But that created a great deal of angst. I could not stand that was happening. It really got to me. And so that created the basis of my entire career. So an EDAP is, and the reason I'm giving you these definitions is just EDAPs are going to come up later. It's an emergency department with specific equipment, policies, procedures to care for children. Children's National would be a pediatric medical center. It's really a regional center in which children are often technically transported to your facility, and you have a PICU, and then obviously about trauma centers. So the EDAP concept is really the first kind of regionalized system for pediatric emergency care, meaning from the field they would be directed to those facilities, and if they were not at those facilities, then they would be secondarily transported either by ground or air to a pediatric critical care center, now in LA County, called PMCs. We also, at the same time that was building, is the nursing component. We had nursing advocates who were involved in improving care for children, quality improvement in a number of these hospitals. And so as part of the requirements for an EDAP, you had to have a physician, a medical director, and you also had to have a nurse. And that whole concept you're going to see later, has become part of what is current national guidelines and also major recommendations from the Institute of Medicine. So anyway, this fully deaf concept was born about by a growing concern that children, the needs really weren't being met, and that emergency systems lacked resources. And having been there in the early stages of all this, everybody said, no, like, what? What are we doing wrong? You know, and you kind of had to point out these things like, what if a child came in and you didn't have the right size blade or an endotracheal tube, or you didn't have a mask, or the nurses weren't capable of getting an IV and you didn't have any other way? We weren't really doing IOs much then. We just started, a little later we started with PALS, we started doing IOs. Very interesting. And as you know, what came out of some of these growing concerns was the federal EMS for Children program. And Senators Orrin Hatch and Lowell Weicker joined Senator Inouye to sponsor the first EMST legislation. And Seaver Coop, he got, I don't know, he got a lot of criticism, but that guy was a real thinker, I thought. He was amazing, and he strongly supported the measure. EMST is all about the continuum of care, from the prevention, pre-hospital component, obviously the in-hospital component, critical care, rehab, and then getting the patient back to their communities. So the program was established and administered by the Health Resources and Services Administration, along with Maternal Child Health Bureau, and NHTSA, our National Highway Traffic Safety Administration, has been a major partner. And so this came about right at the time, the first grants came about right at the time that I was finishing my residency in emergency medicine. So this is called serendipity, right? An opportunity. In addition, pediatric emergency medicine as a specialty really began in the 80s, but it wasn't until the first subboard that we had our first subspecialists in pediatric emergency medicine. Here's some of the first subboard members, which is really great: Bob Luden, Joe Sicardi, and Bob Schaefermeyer. You can see Ron Diekman, Gary Flasher. These are some of the big names. I don't see, where's Roger Barkin? I see him there. And it's very exciting because these are people that kind of I was following pretty closely behind, may I say, in the field of pediatric emergency medicine. And here's in 1992, we offered the very first subboard exam in the United States. So this is from 2012, but this just begins to show you some of the distribution. This is from the ABP side, but there's only about 275 or 280 EM-trained pediatric emergency medicine specialists, but the large majority are pediatric trained. Is this my email? Oh, well, you're going to periodically hear my email ding. But anyway, just, you know, we've got a long way to go for penetrance around the United States in pediatric emergency medicine. Okay. So fast forward a little bit to 1993. The first report relative to EMST came out in 1993 from the Institute of Medicine, and they identified a number of areas that really needed work. Okay, one was education and training, both pre-hospital and in-hospital. Essential tools really weren't in place from a systems perspective, including communication 911 systems, even like dispatch, right? Pre-arrival instructions, you know, so there was a lot to be done in the pre-hospital and certainly in the hospital. Planning, evaluation, and research was really in its infancy. I mean, they were basically a consensus document because there really wasn't much evidence for anything we did back in that time. And then what about federal and state funding to kind of promote this? And certainly the EMS for Children program has been played a major role there. After this report, it led to the development of a number of guidelines from AAP and ASAP. Some had to do with equipment, others had to do with treatment of minors, but both developed some guidelines relative to the care of children in emergency departments. But they really weren't playing very well in the sandbox together, so there wasn't a lot of collaboration at this time. And a number of us at various EMSC meetings got together over perhaps a glass or two of wine or maybe a beer and said, what are we going to do about this? And so began the initial phases of collaboration really between the two organizations to develop common policies to care for children. And really the first policy that came out that I'm aware there was a joint policy was on special needs kids. Nobody had any problem with that, and then later ED guidelines came out. All right, what about pediatric education? Multiple states, I had mentioned to some of you, Washington, Oregon had developed, Ohio had developed really some nice educational schools for pediatric emergency care in the pre-hospital setting. But there was no real national program. And it was in the 1990s that PEP began, and Dr. Ron Beekman, who had a grant, it was funded through EMSC, developed what's called a PEP in California, and I was part of PEP. We ended up partnering with a number of these other states, including Florida, Washington, and Oregon, to develop a task force, and AAP took this on, and in 2000 rolled out PEP, which has now trained about 500,000 providers nationally and internationally in pediatric emergency care. And it's on its third edition, I think, now. How about Dr. Broslow, right? Remember? You don't remember life before the Broslow tape, right? I remember life before the Broslow tape where you go, looks like about a 2-year-old. Let's figure this out. 2 times the age plus 8 to 10, the number of kilos, right? That's how we figured it out. So he was later joined by Dr. Robert Luton in Florida, and they now have this whole Broslow system. But it was really a wonderful invention that I think has really revolutionized resuscitation care for children. Here's something that really helps emergency medicine. This was TV's ER, okay? It was it ran for 15 seasons, and Noah Wiley, by the way, who's in the center on the black and white, was our spokesperson for the initial phases of pediatric readiness here in the United States. So that's kind of interesting.
Where's George Clooney?
And George Clooney. Okay. Fine. Do we need peas ready? I don't know. Let's see. I think we need this way.
Right now, 6-month baby boy with 20 Just want a 3-course crackle by now.
I'll stop till like 75.
Sounds like pneumonia. Let's get a pediatric intubation. Try to move now, people.
You get a line for just PCM.
That was fast. Get her down here now. What's that, 2?
We're going to have to do this.
No, I think I need something bigger. 3.5? I don't know. Clamp down. I can't get the brain in.
Paralyzed.
Well, no. To me, it's weight. Who's wrong with it?
All thoughts is dropping. What's going on?
Difficult intubation. I can't do it without a weight.
That's what the boss will pay this for. Okay, so Medicaid with 2.7 of estrogen, 14 of lighter. That is human blood pressure.
I didn't see the course.
Because you had the wrong weight and the wrong tube. Straight down board. Okay, here we go. I'm in the bag of Dr. Ben, do you want to go to the paramedic truck?
How many patient safety problems do
We don't have that much time.
Yeah, you don't have that much time.
Go over.
That's totally correct. Yeah, especially at the end, interruptions. Oh my God, the list is endless. But these things, but out of, all of this work and issues and everything came the first joint guidelines between the American Academy of Pediatrics and American College of Emergency Physicians on care of children in the emergency department. Wow, it took, over 30 drafts, and we started in 1998, but in 2001, we were able to pass those boards, which was, I remember going to the ACEP board, and they're going, why do we need this? And I go, we need it because we care about kids. And they said, is that it? I go, yeah. I go, okay. So anyway, it was quite interesting. And it was it was supported in concept by 17 other professional organizations, including the Joint Commission, as they were known at that time, and NACRI, who was known as that at that time. But really excited. And later on we'll talk about the Institute of Medicine. But what did they include? Administration, physician and nurses, and we wanted to support the concept of physician and nurse coordinators. And even though we had no data that they actually made a difference, but we thought, gee, it seems like a good idea. And quality improvement and support services and equipment. And you'll see there's some important things that are missing, and we'll address that when we get to the 2009 guidelines. In 2006, the CDC published this on the EPSIS survey, which is part of this sampling of emergency departments that represents all of the United States emergency departments, and what they wanted to know is, are they following these guidelines? And they found that 50% had 85% of the equipment, only 6% of EDs had all the equipment recommended in the guidelines, and this created a huge furor amongst all the stakeholders because they're saying, my God, this makes us look so bad, and we're just trying to do something good. When in actuality, as somebody pointed out, it's an opportunity. It's an opportunity to do better. In 2003, we surveyed the United States as part of an AAP cooperative grant, again expanding on this concept of pediatric readiness. And we surveyed 5,100 emergency departments, but we did a paper survey. And we told them that we'd give them feedback, and all that was good. And we did 5 different contacts, and so we thought we were doing really good survey methodology, but we only got a 30% response rate. And when you're talking about paper surveys, people get them, they file them, and it's just really tough to do a good survey. We also found that only 6% had all the equipment. So very interesting that a totally different way of looking at it, we got to that exact same number. And we developed a weighting scale, which we have subsequently used on the latest assessment, something very similar. You get an expert panel, you look at it, you say what things should be weighted. What are those components of the guidelines that we think that are going to differentiate a ready from an unready hospital and are most critical to care for children? What we found was that these weighted readiness scores were higher in larger volume EDs, no surprise because they get a large number of kids, so therefore they're much more aware of the issues. And we also found a definite association with a physician and nurse coordinator that was independent of volume, okay? So that was kind of interesting, but it was really an association, and we couldn't really say, sorry. We also found that it cost very little to actually implement these guidelines. Overall, it's probably less than $2,000 for any hospital, and that includes the personnel component. But when you're just looking at equipment, it costs less than 18 cents a visit to create readiness. So it would cost less than $5 million for all hospitals to be ready in the United States to care for kids, at least have one of everything. Here's just showing some data that if you have a physician and nurse coordinator, it seems that it's associated regardless of volume. Standby hospitals don't even have a physician there 24 hours a day. They're on call to the ED. A basic ED has no pediatric ward. A general general ED has patients seen together, and they may or may not have a ward, and they may or may not have a nursery or NICU. And obviously, comprehensive centers are it's broad definition, but they include inpatient pediatric capability, including a PICU. When we looked at the median score, it was 55, and if you take it that it's, basically the range is 0 to 100, we really weren't a passing grade in terms of pediatric readiness at that time by this study. And that was very difficult to take by my colleagues in the American College of Emergency Physicians. They were really upset by it, and it created a little bit of animosity, but yet it also created opportunity to try to solve this problem and continue to work together. In 2006, as you know, the Institute of Medicine released 3 reports on the future of emergency care in the United States health system, one on hospital-based care, one on EMS, and one on emergency medical services for children. The motivation was crowded EDs and financial burden of uncompensated care. You can see fragmentation, personnel shortages. We don't have enough nurses. We don't have doctors in certain areas. Limited data quality. We know about inadequate research. We all know about that. And frankly, everybody in this room is part of the solution, right? And obviously, limited preparedness for pediatric patients. In 2001, the Pediatric Emergency Care Applied Research Network was born, and the first really multi-center research that was done in the United States, and it's really, and I know you all are participating here, and I think it's one of the best things that Emergency Medical Services for Children has supported and funded, and they've done some just basically practice-changing studies. So very exciting. So what are the realities of pediatric emergency care in the U.S.? There's a decreasing number of patients being seen, overcrowding. And as you know, overcrowding with adults and overcrowding with children, you get a whole bunch of kids, screaming, crying that you can't talk to. It creates a whole different frenzy level. Yes. And I work on the adult side, so, I say, you have an emergency department full of screaming kids. That's way more stressful than adults, I can tell you. But I love it, and that's why we're all here. The other thing is that for most emergency departments, children are not on the hospital's radar. Okay? And this is something that we had to really ingrain in the Institute of Medicine Committee, because all these people are, in academic centers, and they're going, what is the problem? And you say, you know what, we showed that the average ED sees less than 10 kids a day, okay? So, meaning about 50% of the EDs sees less than 10 kids per day. I mean, how many, 10 kids, do you see that every hour here or something like that? Every 30 minutes? Okay, so you see what I'm saying. I worked in a community ED that saw 10,000 children. We had 1 pediatric intubation that entire year that I was there in the ED. So let's see if anybody's minding that store, right? I did a mock code. Nobody knew where the pediatric intubation equipment was. We even called respiratory. We were bagging the child in this mock code at that community hospital, but it just shows you, and then the hospital saw like 60,000 adults, but they only saw 10 or 12,000 children. Very interesting. So I think we're all aware of the safety risks. So this is why all of these issues are so paramount, right? And why we all have to be part of the solution. I think you guys know all this. In terms of critical patients and EMS, about 5 to 10% of pre-hospital calls are related to children, and most of those aren't sick. And so there's real limited experience in our pre-hospital providers. That's why we have to be simple, teach them what they need to know, right? And teach them what they need to know and give them the tools at hand for basically real-time understanding of what they need to do. And in the emergency department, we know that very few of us are going to see here. It's a different story, but in the community, very few emergency physicians see critically ill or injured children. And this is more recent data from the National Pediatric Readiness. About 83% of children with emergencies are cared for in general EDs in the United States, and half of them see less than 13 kids. And the previous data was about 10. So what the Institute of Medicine, one of the healthcare advisors, said, if there's one word to describe the current state of pediatric emergency care in 2006, it is uneven, meaning there's great centers of excellence, but also centers with considerable challenges, okay? So what were some of the things that they recommended? I'm just going to highlight the things that are in brown here. So basically we need to find what are competencies. What does the average ED doc need to know? How about a paramedic? And then if you work in a tertiary care center, do you need to know more? I'd say, yeah, because you're going to see, post-op heart kids and, kids on chemo. Clinical practice guidelines are going to be more and more an important part of our practice, and we're certainly seeing that today. And one of the things that we imparted, based on really not the best research, survey research, and it was my own, I can say we only had a 30% response rate, and in fact the pediatrics took that, was a miracle, but that was the only data we had. The IOM said all EMS systems in all hospitals need to appoint pediatric coordinators to oversee the care of children and make sure they're taken care of. So somebody has to mind the store, and that was a major recommendation. Super happy about that, okay, that actually went through. These coordinators are local thought leaders who can bring about institutional change to improve care. And some of the things that they do are what you see here, liaison with various committees, patient safety, education, quality improvement, and they help ensure appropriate planning for disasters. They can be shared, so that's really important in terms of cost to the system. We were really concerned about saying you need a PGM physician in every ER. That's totally impractical. You saw the map, they're not going to be there. So we had to say they had to be a shared role. What about quality? We really need more studies on efficacy, safety, health outcomes. Some of you are doing some of those studies, the whole communication handoff that you're working on here. I mean, that's really cool. That's part of quality. And how can we better transfer care to other providers so things don't go awry? We want to develop some things relative to medication dosage guidelines, using electronic healthcare record to help us in that. That's all really important, right? And develop those tools. It could be automated tools, and it could be like the Bravo tape. And we have to develop some strategies to reduce error. We know that error occurs all the time. I heard you had an event today. We have events all the time too, right? So these happen. Even in the best places, events happen. So you have to have ways, evidence-based ways to reduce those errors. The other thing is a lot of devices are made for adults. So what about, making devices specifically for care of children? So there has been real federal support now for device manufacturers to develop pediatric-specific tools. And one of the things that I know you guys do well here, and was a big area of interest for my mentor, Jim Fidel, was family-centered care. The idea that you involve families in the care, it's going to not only improve their satisfaction, but improve their safety. And we've all seen that. The classic example is as part of family-centered care, you say why you're doing things to their children. And I was working at a community hospital, and one of the nurses, we introduced family-centered care, and we say, every time you come up, you need to say, hi, who you are, and you need to make sure you identify that it truly is the caregiver, right, the person responsible, and then you have to say what you're planning on doing. So the nurse said, I am nurse so-and-so, and I understand this is your daughter. Yes, yes. Okay, we've got some medicine here for diabetes. And as she started to inject it, the mother said, my daughter doesn't have diabetes. The person on the gurney next to her. So that is a dramatic example of how a basically life-threatening adverse event was avoided through family-centered care. very interesting. We all know about children in disasters. Certainly this has been a part of all of your lives. It's now part of our lives. I remember waking up and watching the first plane go into the building and just sobbing, going, our lives have changed, and they did. You know, in the future, we just have to be aware of the world, and we're part of the global humanity, and we have to be able to address that and care for ourselves. In 2009, it was recognized finally that we got smart and we partnered with the Emergency Nurses Association. Who are the people that get the job done in quality improvement? It's those darn nurses. So they are our partners. And so we partnered with the Emergency Nurses Association, which was fantastic, and they have really been advocates for pediatric readiness in a very big way. And the other thing we had to do is we had to update some things. One, we had to put in disaster planning. We didn't think about that in 1998, right? The other thing is patient safety. It became more and more clear that there were many, many safety events relative to care of children, especially weighing them in pounds, or just saying, how much do they weigh? Oh, okay. Writing down 29 and then delivering 29 kilos. So very, very important for us to add safety issues. Now it's endorsed or basically supported in concept by 22 organizations. And the presence of a physician-nurse coordinator, we felt, is probably the most important factor, even though we didn't have great data to support it. We knew that our previous survey had, the Institute of Medicine had recommended it based on a lot of testimony, and finally we go forward. So, you've heard about Malcolm Gladwell's tipping point. I really felt that we had a tipping point with the National Pediatric Readiness Project. I had been involved in pediatric readiness issues my entire career, and I felt like we were going somewhere but not fast enough. And Dan Kavanaugh, who at that time was the director for the EMS for Children program, and then passed the on to Dr. Egerton, who trained with us at Harbor-UCLA.
But was also here before she was here.
Right, and she was here. Mm-hmm. So Dan, I had talked to Dan. I said, you know, we've got some extra rollover state partnership monies, and I want to do a web-based survey and provide immediate feedback to all of our emergency departments in California, and can we do it? And I said, I got a guy who does, you know, PlayStation video programming, and he'll do it for free because he has a daughter, and, you know, it's like one of these things, right? So Dan said, that's a really great idea. And so we asked for these partnership funds, and they said, yes. The next thing I know, Dr. Egerton called me and said, oh my gosh, congratulations on your position. Here's how you doing. So anyway, she said, can we partner with you in the Pediatric Readiness Project? And I said, oh my God, and I literally, you guys, I literally got extremely tearful, and I thought, you mean we're going to roll this out nationally? And she said, yes. So that's the tipping point. Very interesting. You never know when it's going to happen. So why now? Almost 30 years of advocacy. I don't know if you remember Marty Eichelberger, who was here. He's still here? Oh my God. Okay. Many other people, like Dr. Chamberlain and myself, have been involved in the advocacy, but these are all very important people in advocacy for EMSC over the years. And thus was born a concerted effort to develop a national assessment, which would be the very beginning part of a national quality improvement initiative that would be a national effort amongst a number of stakeholders. And we call it the National Pediatric Readiness Project. I am really into logos and branding. And I hired a graphic designer to come up with the branding for the National Pediatric Readiness. I had to sell it, right? Do you remember? You were at that meeting, right? I go, come on, you guys, we need to set ourselves apart as a real initiative, and the only way we can do that is different than every other EMSC initiative is to have our own logo. And so, and thus we did. And then finally, after a number of years, we initiated a national assessment of all the emergency departments in the United States. And we did some very unique things, which I felt pretty strongly about, and I think our expert group also felt strongly about it, to be able to give immediate feedback. And this is our publication, which is in JAMA Pediatrics. It came out April 13th of this year. You can't do anything by yourself without the federal support of the EMS for Children program and all of our stakeholders, and actually all the grassroots people, which were basically the EMS for Children program managers, who were heavy lifters in the various states and territories, were absolutely critical to get this done. In California, we had reached out to some of the apps. How do you get this out there? You go to the hospital association, you go to the professional organizations, you present to the EMS agencies. In California, all of the local EMS agencies were really, got totally behind it. And so it really helped us implement that in California. In Texas, they did something different. Here in the district, I don't know how you did it, but, you know, you get the job done, and the program managers were important. It was a comprehensive web-based survey. We sent it out to over 4,000 emergency departments. And here's our team. These are just a number of the stakeholders. As you can see, a lot of these people a lot of these organizations are familiar. The Hospital Corporation of America, there was a thought leader, Sue Cadwell, who was one of the vice presidents of that organization, was very interested in Peds Ready and had done her own Peds Ready initiative. So she was a great thought leader to help us frame some of the way that we presented this to other emergency department leaders. So we really wanted to assess Peds Ready, and we wanted to really try to get a better picture of the effect of the physician and nurse coordinator. Since we looked at it before and we thought they were important, we just really wanted to find out if they were. And we also wanted to find out what the gaps were so we could target future initiatives. So ED managers were identified. What we did is we sent out letters to ED nurse managers, ED medical directors, and the CEOs of over 5,000 emergency departments in the U.S., okay? We used the American Hospital Association list. It was vetted by all of our program managers, as well as those lists were vetted by other people, like we had the local EMS agencies help us in California. We created a web-based assessment based on the guidelines, and we implemented it. And again, I already talked about this, and this was absolutely amazing part of it, and I think the NRC was very critical here, as well as the NEDAR. So the assessment basically covered 6 areas: administration, staffing. You can see the 2009 guidelines. They were weighted. We did a similar process, like a modified Delphi technique, where we went through and we said, score this, score that, then we talk about it, come to some consensus, everybody rescores, and then we take only those scores that people felt had basically an importance of 2 or greater was considered to be weighted. Everything else was considered not as important and was not weighted.
Scale of 1 to 5?
No, 1 to 3.
1 to 3.
All right, so believe it or not, we piloted this. We had to because we knew, well, California was basically a massive pilot. Okay, we rolled it out in California first, and then we said, ooh, what do we do right, what do we do wrong, and then we went national. I'll explain that in a second, but there was 55 questions, and so how long was that going to take people to do? What we found is it took them about 30 minutes to an hour to do. Some couldn't do it at one sitting, and so we had to set some rules on, how to come back to the survey to make sure it was accurate, you had to do it at the same computer, the same person had to come in and finish the survey. But we recommended that they print it and that they work with their medical director and their administrators to get the information that we needed. All right? And believe it or not, it's like unbelievable how many people actually responded to this thing. And the study was approved at the University of Utah through NEDAR. So our main outcome was the weighted pediatric readiness score, and we adjusted it for the number of points that you got to be a pediatric emergency care coordinator, physician, and nurse, in order to look at then what was the effect of adding those back in. What were the incentives? Okay, this turned out to be critical. When you do any type of survey methodology, what are the incentives? So we could either give money, which was ridiculous. We couldn't give all 5,000 some cash. I guess we could give them $1, but no, we didn't. Right? You get the dollar, you know. Yeah. Take that $1 and throw it away. I feel guilty taking the $1, right? You get what I'm saying? I just give it to a homeless person, you know. But so one of the things I felt strongly is that people want to know how they're doing, and they want to know how they're benchmark relative to other hospitals. So we did this. NEDAR was so great, and we used a checkbox, and they were able to. That's the program that we used, and it allowed us to do their immediate score, weighted, preparedness score, how they are relative to like hospitals, meaning small community hospitals, et cetera, versus large hospitals, and then how they do in relative to everybody else who answered the survey. Really cool. So it popped up, okay, our score is 68. We're not doing as well as some of the other hospitals like us, and everybody else in the country is doing better than we are. No, it gave them a rough idea of what's happening. In addition, so this just gives you a rough idea on how everybody scored. We separated the hospitals into quartiles, and so the lowest volume hospitals scored 62. You can see all participating hospitals scored 69. And the high volume hospitals like here. By the way, high volume is considered over 10,000 children a year. That's considered high volume.
10 times high volume.
Okay. So is anybody in my reality yet? Right? And the reality is you got to think like they think. And you can't think like they think because that is not where you practice. So you've got to really work on that. And so that's part of the things when you start to go out and reach out to community hospitals. You got to realize they're seeing very few children. All right. Let me keep going. Okay, California served as a pilot, state to test this, and of course we had to have our own logo. Because, you already know I like logos. If you know anything about the Peaks Airway Project, we had a really cool logo. Anyway, this was pretty interesting. We partnered with the state of California, the EMS authority for the state, and all of the 32 LIMSs at the time. This just shows you a gap analysis that all the hospitals got. So when you finish this, not only did you get a score about how you did, but you're going to get a score on, you're going to get a gap analysis that tells you what are the top 3 things that your hospital has to do. This happens to be the state gap analysis for California, so it's a little different, but you get the idea, right? So every hospital was literally armed with their score, how they're doing relative to everybody else, and what they need to do to get better. And because of that, I really believe that created and incentivized, as people talk, to participate in the project. We rolled it out in 5 cohorts that we field tested, obviously in California, you heard about, but also Guam, Maryland, and Minnesota. And the reason we did is because from California, we had to make some changes. We know that of the people that didn't respond to the survey, okay, 90% of the hospitals responded in California. What we found out is that they stopped at the question of what is your pediatric volume. So we made that in the national, we made that optional. We also said you could just say, do you think you're low? Do you think you're medium? Do you think you're high? What's your gestalt?
They just didn't know.
They didn't know.
Right.
Wow.
Yeah.
Wow.
we rolled it out, we had an 83% response rate in the nation. It's like unbelievable. Every week, it's really fun, you guys, when you partner with people, right, every week people were like emailing each other. And then I did something for NEDARC and they'd say, they go, we're at 50%. I'm going, oh my God, that's amazing. We're at 60. And then when we get to 80, we're going, oh my God, we're going for 100. You guys, let's do it. And then they said, Marianne, get a grip, you know. But it was extremely exciting, and it was due to like considerable partnership. So this represents probably 24 million of the 27 million visits for children in the United States. And you can see 69% of EDC less than 15 or 50% EDC less than 13. And almost a third of the hospitals are located in rural or remote areas. This kind of just shows you, you can see 30% see 5 to 15, 39% see less than 5 children a day. See less than 5 kids a day. Now we're asking them, we're not going to ask them to have rib spreaders, you guys. Okay, you can't ask them to have rib spreaders. So this is where reality sets in, right? So here's how everybody scored. You can see all hospitals, average score of 70 or 69. This is way better than the 55 that I had reported back in 2007 from a 2003 survey. So 10 years later, at least we're doing a little bit better. Interestingly enough, the number of physician and nurse coordinators back in 2003 was somewhere between 12 and 18%, and now it's in the range of 50%. So I think there has been impact by advocacy by all the stakeholders. Anyway, so this just shows you the various hospitals, so 3% rural remote, and really most of the hospitals, 85% are either basic or general. So they're not really comprehensive hospitals. And you have about 4% standby. So you're only talking about 9 or 10% of the hospitals in the United States are hospitals like you are here at Children's National. And most of them aren't like here at Children's National either, you know, even if they're quote-unquote comprehensive. Interestingly enough, when you look, 42% had both PECCs, but about 50% had nurses and a lot less had physician coordinators. But when you look at who's taking care of kids, as you get to the high-volume hospitals, you see 88% are board certified, and then they may have some family medicine. When you look down to the low-volume hospitals, you can see that, let me see if I can do this. You see there's a large amount of family medicine. So we had known this, that family medicine was involved, even though they don't get a lot of emergency training. We had family medicine representation on all of our planning committees and for the guidelines themselves. So hoping that the word gets out to them, but there's a real opportunity for somebody to really work more with family medicine and see if we can improve care in those hospitals. And then you can see that in terms of quality improvement processes, a low-volume hospital, 2/3 of them or more didn't have a QI plan for children, as an example. They just don't, you know, they don't put kids in a QI plan. And high volume, almost 80% had a plan. So you're thinking, how can that possibly be? Now, some people probably misunderstood the question, but others didn't have specific indicators for care of kids. And then when you look at required equipment, you can see that most people have a large majority of the equipment. 87% of the EDs had, you know, really most of the equipment, okay? So 91%, 98% in the high volume had all of the equipment. When you look at the impact of a physician and nurse coordinator, regardless of volume, and now we've got a massive sample of the United States. Regardless of the volume, the presence of those coordinators makes a significant difference, as you can see. Okay? When you have both, it really matters. Okay? Because they do different things, right? Really cool. So I think this is the first time that we've shown a really big association. So we talk areas of the guidelines in the section. If you have at least one physician or nurse coordinator, you can see as an example, you're 4 times more likely basically to have a quality improvement plan if indeed you have a physician or nurse coordinator. Pretty cool. About 81% reported barriers and cost of training personnel and education are up there. So really clever ways to train personnel and to provide education of personnel without having to go on site. One of your fellows is doing telehealth, and so maybe doing, smartphone apps, talking about real-time pediatric emergency care. So it looks like we're doing better. This just shows you relative to data that we had, and we reanalyzed our data based on the court files that were used for National Peds Ready. And this is what we got. It looks like in all volume categories, there was, we feel, significant improvement in pediatric readiness. So the compliance really with the ED guidelines has improved. The assignment of a physician or nurse coordinator really does probably have an impact in terms of readiness. Barriers are common, and so that is an opportunity for all of you to figure out clever ways to deal with that. And we really feel that I feel that the NPRP was a wonderful way to translate research, meaning that just doing the assessment itself was able to inform over 80% of the emergency departments about the guidelines and the pediatric readiness site. So it's really kind of a cool way to roll it out. And we're really ready for our next steps. And I know Kathy's going to be involved and Joe and all of us. I'll tell you just briefly about California, and I think I'm just about out of time, but I only have a few more slides left, so I'm gonna rock this. This is where we went in California. We did our statewide assessment. We were the first to roll out, and we looked at all 335 acute care hospitals. We had a 90% response rate in California, and I think if we did not, I don't think we would have rolled out nationally. So there was a lot of pressure on us in California to get the job done. You can see that about 50% had pediatric coordinators and 43% had QI, but you're much more likely if you have a PEDS coordinator, obviously, to have a QI process. I want to just talk about verification because we were able to get a little bit more granular with PEDS Ready in California. And we really wanted to look at areas that had verified pediatric capabilities, meaning like an EDAP, which you guys all know about. So in Los Angeles, there's 73 EDAPs, 73 hospitals, 29 are non-EDAPs. And basically, EMS says you can only go to an EDAP. Okay, so 911 won't take a patient to any ER, but only those that are verified. Here's the difference. Nobody's ever shown that. We are there is a clear association with being an EDAP and being pediatric ready. So verification makes a difference. What's fascinating, okay, let me talk about we said, okay, is there something in LA County that's different about the rest of the state? And in actuality, there's nothing different about being in LA County that's different except for being an EDAP, okay? Interestingly enough, when you look at the different volume classes, you can see that of those that are verified, and there's smaller numbers here, but you can see it really makes a difference. There's some EMS systems that say, we assess them. So what does that mean? Assess means they call them and they say, do you have everything you need to care for children? And they say yes, but they don't necessarily do any on-site verification. So we really believe that on-site verification makes a difference. Now, it makes almost no difference for the high-volume hospitals, okay? Now, those who are not assessed at all, nobody ever calls them and talks to them about it. They're almost like everybody else, right? But if you're verified or if you're at least assessed, you're going to do pretty well if you're a high-volume hospital. But really, verification is what makes the difference. And if you look at the difference in the various sections of the guidelines, This is a little bit difficult to see, but you can see overall that verified versus assessed versus non-assessed. And this includes everybody, so it averages out everybody, even the high-volume hospitals. So the bottom line here is it looks like there is an association. You can't say it's statistically significant, although these numbers are in and of themselves different. There is an association with verification. Here's something fascinating. If you look at level 1 trauma centers in the state of California, this is the number of level 1 or 2 trauma centers, you can see that they scored really high on the readiness score. However, after we adjusted for those who were pediatric verified, it made no difference if you're a level 1 trauma center than if you were a community hospital. They didn't have the same readiness capability as the verified facilities. So if you verify for, you'd think a trauma center would be much more capable. It was only a 2-point difference if you're a level 1 or level 2 trauma center if you were non-verified. Okay, non-pediatric verified. All trauma centers are verified. I find that fascinating. Don't you find that fascinating? I mean, that is incredible. So, you know who's a target stakeholder? ACS. What are you doing when you survey these people? Mm-hmm. You ask about pediatrics, where's their equipment? Do they, blah, blah, blah. So there's an area that we can make a difference in pediatric trauma care. So there's obvious benefits to verification. I'm almost done. Kaiser Ready just rolled out and we implemented. And what happened in Kaiser, they were so upset by their scores, they developed a regional task force to improve readiness amongst all their hospitals. And we just surveyed them, and I can tell you the difference is pretty dramatic. So we're very excited, and we're in the process of calling all of those hospitals to see what did they do, what did they participate in as part of kind of a quality research project to see, to be able to, report back to all of you. And next steps, certainly encouraging coordinators, quality improvement plans, some of you involved in quality, getting involved in creating those quality metrics. We're going to be working with stakeholders. And how can we influence change? Many of you have asked me these questions, I think. Knowledgeable, obviously, you have to have passion. If you don't care about, you don't sound excited, okay? I'm excited, okay? Can you feel that? I'm excited. So if you're passionate, people are going to be excited with you. You also have to say, we can do this, okay? You guys are really the next soldiers in this mission, All of us are going to, we're going to be, us old folks are going to be retiring eventually, and we need you. So I'm going to leave you with the message, which the mnemonic is EMSC. You need to educate, motivate, you simplify your message so that they can carry it forward and you communicate your ideas to as many people as you can. So the future basically is ongoing advocacy. I can't speak anymore. And, they continue these quality efforts and essentially by having the portal remain open. Community engagement is something that I know, Joe, you've been doing, and that is really important. This whole community benefit idea, and I'm just wrapping my head around that. I am so into this now after getting your email last night. So over dinner, he tells me about community benefit, and now I am on the bandwagon for community benefit because this is a way to roll out pediatric readiness. And anyway, I think I've been in there in the interest of time. Thanks, you guys. Any questions? Yes.
Did EMSC put into their performance metrics for state partnerships how many hospitals have pediatric coordinators?
That's interesting. I don't know. Is that a new performance metric?
So the performance measures are being changed shortly, and I don't know exactly what they're going to say, but I think that is something.
But I thought that was on the previous.
No, it's not now.
Previous one. The new performance measure is going to be
to increase the proportion of hospitals that have a pediatric coordinator, right? Because I remember reading it in one of the.
Or at least one of the coordinators would be a great start. I mean, obviously both coordinators would be ideal.
Definitely not a performance measure now.
No.
Well, it's not one now, I know that,
Yeah.
but whether.
Just so you guys know, because I've gotten a few texts and questions, this is Tony Gilchrist from EMS for Children, the National Resource Center. He is one of the program managers there, and he does a lot of work with us. And then this is Cynthia Lightfoot, who's the program manager for the DC State Partnership Program for EMS for Children, who also I work with very closely. Kathy and I do, so just so you know who they are.
The National Resource Center was Joe's baby.
Right.
Until he left and went to Howard and he passed it off to Kathy.
Yeah.
Which has been an amazing resource center. I mean, has done incredible work, so we should all be very proud of that here. Based here, Children's National, so you guys are really
Busy.
yeah. All right, and
I have a question about the response rate. You know, so that's to me one of the most impressive things about the effort is that you were able to get 83% of 5,000 PDs, you know, many in very remote places to respond. So, you know, one thing I think you already mentioned was the feedback. You think that was important as far as an incentive. What else? Any other ideas about how that was achieved?
Because this was taken on really by all the stakeholders in a very serious way, it wasn't just like what happened with me in 2003 is I'm the lone person carrying the banner saying, please answer this survey, it's really important, okay? Well, it doesn't go anywhere. What talks is when every meeting you go to, somebody talks about it. Every committee meeting is presented in education. I mean, just personally, I've done probably 40 presentations on Peace Ready over the last couple of years, and that doesn't include all the other people who've done Peace Ready, Kate Remick, yourself, I'm sure, many of the pediatric committees for ASAP. And AAP. So there was a lot of stuff that was out there, and it was clear that it was part of the national agenda for those three organizations, as well as the Joint Commission, interestingly enough, sent out something saying, this little survey, like a, survey monkey, are you interested in pediatric verification? And I think people started going, oh, my God, we better pay attention to this. So there was a lot of things that were happening simultaneously. In addition, the program managers really took it on, don't you think?
The program managers, the tenacity of the program managers made a huge difference. And their networks within the state with their state DNA and their state ASAP.
Right.
And it really became a obviously collaborative project amongst all the players, and that made a huge difference.
Yeah,
You just hounded people.
I was going to say that utilizing that existing network, I think, was important. But also, the states competed with each other, at least regionally. Like, Cindy is still upset that DC beat her in percent.
Right.
We didn't beat her in score, but we beat them in percent. We got all 8 of our hospitals to respond.
That was a nice lesson learned in terms of survey methodology for national surveys, to roll it out in cohorts.
Yeah.
So that the subsequent cohorts were seeing what the previous cohorts did, and it became a competition. And they were like, oh, we can't do that.
Yeah, I got email competitions from Texas, and they were saying, we had more hospitals respond than in California, and I said, you guys didn't get nearly the response rate we did,
Yeah, that was me at the time.
Oh, that was you.
Yeah.
That's right, that was you.
Yeah, we had the most hospitals of anybody.
It wasn't a lot of
But we got the 60%, which was more hospitals than she had in the state.
Wow.
What's interesting for me is that a lot of the hospitals now want to retake because they've added some things, whether they're courses, and the opportunity to do so. So again, that competition and raise their individual scores is important to them.
Yeah, I think we're talking about it on a national level. I really feel so strongly, too, that it's such a great longitudinal longitudinal quality initiative, and people can continue to benchmark themselves. You know, you could be part of MOC, you can be part of lots of things. Anyway, Jim.
Do people ever equate CS greatness with verification for taking care of kids, and is that a threat? I mean, if you're going to take away 30% of my revenue, well, probably 20% of my revenue, by taking away kids, that's a big threat.
Right. You know, in Los Angeles, it turned out initially there was a big cure, oh gosh, and then now it's not at all. It's just the way it is.
They just gave up kids?
No, 90%.
Right?
Yeah, you know, 95% walk in, so you realize it's not that big of a deal. It's just only the sickest kids are going to be taken to those places that have policies, procedures, ongoing education. We actually require ongoing education.
So parents don't pick up on that?
Some parents do, but again, community engagement is the next step, but certainly in Los Angeles.
How much to the general public has this been advertised, or like on New York Times or LA Times, or for the communities?
I was in the Wall Street Journal.
There was a lot of press after this.
We, I got a report basically from JAMA Peace that said the reports on Peace Ready went to 163 million people.
Wow.
Yeah, we coordinated a whole press release with the three organizations and Marianne and the authors. So there was, and ASAP and other places got requests for information and for speakers.